Yes, DRTB in the context of tuberculosis, which is my domain, actually means drug-resistant tuberculosis, and that refers to tuberculosis cases that are not susceptible to some medication that we conventionally use for tuberculosis treatment. Commonly, we have rifampicin as one of the drugs that people have drug resistance to, but moving forward, we've been seeing a lot of other people having other forms of drug resistance apart from rifampicin. We have other drugs, what we call the fluoroquinolones, we have isoniazid, and several other medications that that could be found not to be sensitive to the conventional drugs used for treating TB. So DRTB is actually a very big problem in our program because DRTB is a result of people having tuberculosis and being exposed to the medications and not completing the right duration of it. Commonly, we should have exposure for close to 6 months for these drugs, but for some people, when they take it and within 3 weeks they feel better, they tend to put the drugs aside, and that's one of the reasons that causes the drug-resistant tuberculosis. Also, other causes that we know is as a result of, still in that same line though, is a result of people having access to some of the anti-tuberculosis medications as over-the-counter medications from some pharmacies, shops, and the rest. Like rifampicin, you go to the average pharmacy or shop or patent medicine vendor, they give it freely for cough, and of course they don't give it for the right duration. So for that reason, these people tend to have drug-resistant tuberculosis.
One of the things that makes us to know are symptoms that the persons manifest, and these include cough for more than 2 or 3 weeks. We have fever, we have night sweat, we have loss of weight, we have chest pain. We have all these symptoms that are put together. But most of the things that help us to establish that the person actually have TB is we carry out a test, sputum test, to establish the existence of TB in such a person. Now, when we are now talking about DRTB, that leads us to the types of TB. As it is just an infection that starts from cough. And so we have this myth that the normal thing is that when you see people that are coughing and you educate them, you tell them to go for tests, there's always what they always say that a chicken does not die because of an infection on the legs, and so that it's just an ordinary cough. And because in those days, our parents used to use different types of local things to treat cough. I remember if you are coughing, they will tell you to eat bitter cola and tom-tom, it will go. Or you put some lime water inside palm oil, you just mix it together and then it will go. And so they don't believe that cough will actually kill. What is cough? Cough is gotten from catarrh or from cold, and so it doesn't really lead to death. And sometimes when it begins to advance, with different types of symptoms, and because the main thing that you will see with somebody who has TB sometimes is loss of weight, and when the person begins to lose weight and is just coughing, they already believe that cough does not kill, and then you see the person starting to lose weight, then they begin to run around that probably it's somebody that is doing that person. It is called by diabolical means. Somebody in that person's house is the one working against him. No, they are sucking the person's blood. And they begin to go from one house to the other, probably visiting Abalis. In fact, we have had people who have gone to the mountain top to go and treat cough, that we had to go and retrieve back home. Okay, it's one enemy that is doing them. They will have to use anointing to cure it and prayers. Yes, we believe in the power of prayer, but these are just myths that surrounds DRTB or TB when people have it. They believe that probably is somebody that is after their lives that want to kill them. But in the actual fact is because they are ignorant about what we are talking about. And even when you try to educate them and tell them that, okay, these symptoms you are having, this is what is causing it, the next thing they will tell you it is over their dead body. I know that as a DRTB focal person, I've been home to people to visit them, to educate them. I've been placed on, they have abused me and said, it is you and your family that will die of this cough. No, this cough does not kill, and so many other things like that. So people sometimes, they do not have the right information to know that actually cough kills. And when you are even trying to educate them, they look at you as if you are strange. Are you not in this land? Don't you know that we have some other things that can cure these drugs? but eventually when they go up and down, they come back to you, say, okay, aunty nurse or health worker, that thing you were saying before, I would like to try it. I think this cough is not good. But if only that we have more education and people get to understand, we'll be able to dispel some of these myths in their hearts, and they will be able to come out for treatment.
Yes, for TB is just tuberculosis, and it's an umbrella. It's an umbrella, and TB is tuberculosis, and it has different categories. Like as regards DRTB, we're talking about drug susceptibility categorization. Drug susceptibility means the medications that's whether the TB strain that is seen is susceptible to the normal drugs. We have rifampicin, isoniazid, pyrazinamide, ethambutol as the basic medications. So for TB that has resistance to any of these drugs, that is now the DRTB, drug resistant TB. While those that don't have resistance to any of those 3-4 drugs is now called the normal, what we call DSTB, drug susceptible tuberculosis.
The very first one is witchcraft. They so much believe that DRTB does not have a cure. That is a witchcraft, man-made spirits that causes DRTB. And some of them believe it's generational. From my forefather that had it, that is why I have it. Some of them believe it is because of what they eat that makes them to have a DRTB. Or some of them believe that it is someone that put it for me in my drink, that I drink it and have. So many of them, it needs more sensitization and creation of awareness before some of them will even come out from their belief. Mostly they believe it's witchcraft. And in Aquarium, our religious is hard, and we have so many small churches and big churches that will tell them, don't ever take that drugs. Some pastors will tell them, don't take it, it will go. It will just go like that. So some of them so much believe on what the pastor says instead of what a health worker will tell them. So some of these myths and misconceptions will make them not to take their treatment.
She gave me drugs for cough and I took it. Doesn't respond. I take malaria medicine tablets because it's free day. They are giving malaria tablet free. I took it, no way. And I now went to pharmacy. I go pharmacy, they know different types of cough drugs. I took it, no way. I now went to one of my friends introduced me to native leaf for cough. I now take that one. The thing, I'm then it told me man cough. I saw what to do. I now went to that my auntie again. Get that health center. Mo yeke ikonga de so di stop. Ke ibara te me ba. I mo ki ya introduce me to TB person, the one that collected my sample. I can test. I didn't matter on feel it to relax that ke many hope ke yang queen. So when once I test. Never can just only at least treatment to be the better than the other one. You didn't buy sample, even a car can taste. You didn't talk on that kid TV. Kid back by you. Kaya neighbor. Then no most of another stay in Queen. Can that ever contact it? But I should not take any other bit this thing cough treatment again or native treatment. By that time, get mine and make it relax.
There used to be, but currently a whole lot has been done. Research has been going on, and to reduce the peculiarity. Formerly, the patients had to be admitted in a facility giving injections for close to 8 months, a stretch every day, and take some other medications. But currently, the patients are being treated in the community. They all have pills working for them, even though there are quite a lot of medications they use. But as time moves on, we are looking at a possibility of moving to a 3 regime medication. Just only 3 drugs will be used to treat some, like the 7 to 8 drugs that we use in our state to treat these patients. And with that, I know that there's a lot of hope, as regards treating GRT, even though we don't want to see them. But if we have to see them, we'll be able to treat them using just the 3 medications. But for now, it's all oral medications, and it's the best thing that's happened to the program, because it's not easy to give some injections for 8 months running, for GRTB, because those medications were not available in oral forms. So because of that, we had to be giving them injections. So that has been pulled out at about going to 2 years now. And moving forward, we're hoping that within this year, we'll be able to see where they'll even have the 7 to 8 medication being pruned down to just 3 medications for GRTB treatment.
Abẹ́rẹ́ yẹn ẹ̀ẹ̀kan náà ni ẹ̀ẹ̀kan abẹ́rẹ́ náà gbòógì ni tí wọ́n bẹ tí bọ́ yẹn dì báyìí tí wọ́n bẹ fún sí ẹ wò àwa gbẹ̀dì sókè báyìí àwa ara àbòlíkí sẹ́ẹ̀rì oúnjẹ tẹ́ ń fún wa bàbá oúnjẹ ni oúnjẹ tó bá sanjọ́ gan ò lè jẹ ní ń fún wa ṣùgbọ́n ẹ wò bẹ́ẹ̀ rántí tó ní màmá gbé gbogbo ìgbé wọn ìyàwó mi ní nílò jẹun àmì ọlọ́mọ bìí ọlọ́mọ bìdàmì wọn nílò jẹun táwọn dábàá ti lo abẹ́rẹ́ yẹn tán láti lo oògùn yẹn èmi 18 èmi 15 gbọ́n oògùn yẹn dẹ̀rẹ̀ ìgbésẹ̀ wà jẹ́ mílíọ̀nù lọ́dọ̀ mi ṣùgbọ́n sẹ́rẹ́ abẹ́rẹ́ yẹn la máa ń sá fún ṣùgbọ́n ìsá fún kankan rí o ọgbà tó pé ìbí mi gbùgbò ní ìgbà tí mo dé gbùgbò but èèyàn mọ̀ pé gba nǹkan àwa gan ìdíwájú bọ̀ wáyà là wà lọ àbòlúkú mọ́ àwa lọ ra oògùn kan ìtẹ́pọ̀rọ̀ la wà mú tàwa mú àmọ́ bá bá àmọ́ fún ìlàjì báyìí kúnlẹ̀ báyìí ní kọ́bọ̀dù mi ló kúnlẹ̀ báyìí mílíkì wo ló mú ẹnì kankan lè jẹun nígbà tó wá ń pẹ́ dáadáa
ìgbà tí ìpèníjà tí mo ní àwọn àsìkò yẹn ni pé gẹ́gẹ́ bí àwọn elétò ìlera ṣe máa ń sọ pé bí ó ṣe máa rí ní ara èèyàn rí ó máa yàtọ̀ tó bí ó ṣe máa rí lára èèyàn bí, nítorí pé ẹran ara yàtọ̀ síra wa. Àwọn kan wà ní ọyẹ́ pé tí wọ́n bá lo oògùn náà tí wọ́n bá sùn kalẹ̀ báyìí ẹ máa jí wọn, ẹ máa ní bóyá wọ́n mu ọtí ni torí pé ó máa ń ṣe wọ́n bárabàrà. Ẹlòmíì bẹ̀rẹ̀ á lò eégún ẹ máa lé sí pé lágbájá ṣé wọ́n kọ́ ló lo oògùn sí ni, a ní wọn ò mọ̀ kankan lára. Kò ní ti tèmi, mo kàn máa mọ̀ wípé tébì bá fẹ́ gbé mi kí n bì, tí ó bá dẹ̀ ti mú ibi wà kó ń máa kùn mí kí n dijú mọ́rí láti máa sùn, ṣùgbọ́n gbogbo ohun tó ń lọ ni mo ṣe kéde ni mo fetí sílẹ̀ sí ni mò ń gbọ́.
Good enough. It's like you looked at the crystal ball to ask that question, because I was the GRTB focal person in the state before I became the program manager, and it was a very wonderful ride, for over a year being the GRTB focal person and the deputy program manager there, because we saw so many things. It was very difficult. First of all, people had a problem with accepting the fact that they have the disease. They found it difficult to say, no, it's not my portion. That is actually a major challenge we have with it. Then, coming to the programmatic part, we look at the fact that most times we have difficulties with finding these cases after they've been diagnosed because of poor indexing of these cases. Patients don't have the correct contact addresses. Even though they are correct, they are not quite descriptive. So for that reason, people don't get there. The phone numbers might be wrong and all of that. And for that reason, it's a difficult finding these cases. And for us not to find these cases, for every year, they are spreading to 10 to 15 people. So it was a very major challenge with us. So we had to scale up with letting our healthcare workers, our field workers know that you have to make sure that every person that is being tested must be well documented. You must place the contact addresses must be very explanatory so that you can know the person's address, as much as even having landmarks around the houses. Maybe a church, maybe a town hall, maybe whatever facility that is close by to identify the person's house, must be clearly stated on the request forms. Another one is also a challenge where I also know is the pill burden. Formerly was injectables, good enough when I started the tablets, but even with that, it was still a big challenge because the tablets are quite much. I actually went on a patient visit and saw a patient swallow close to, I think it was close to almost 30 pills per day, and it was not a very funny one. And she just said, "This is what I go through every other day, doctor." And I understood her pain, because at times you have even up to 5 pills to take at once, and you're like, "What is this?" Then so having something to take up to 20 pills. So the pill burden is quite a lot for this patient, and for that reason, most of them even choose days to take some particular medications. Even though this particular regime we use now is less problematic than the previous ones, but we know that there's a lot of pill burden. So it's like removing injections and giving you a whole lot of tablets to take. But I know that as we move on to the smaller regimen, like I mentioned earlier in the interview, that you'll see that it will get better. It surely would get better. Another thing is also care. You know, these are people that come from very poor background, and for that reason, they don't have very good food to eat. They have low immunity and all of that. And for that reason, even though you are treating the TB, they don't really come up as well as, because you know, in medicine, when you are treating in the convalescent period, there's a whole lot of things you need to do. You need to increase your protein intake and a whole lot of that. And those are things that the patients can't really do. They can't really, because most of them are even finding it to have the conventional means, not to talk of having these, as we call it, like augmented means for convalescence. So that's an issue. So a whole lot of them are doing better, microscopically, as in laboratory wise, are doing better. The TB is going down, but physically and clinically, they're not looking, they're feeling better because they're not eating or doing what they're supposed to do. A whole lot of them equally lose their source of livelihood, because by the time they're ill, they tend not to go to work, they don't go to their business places, and by the time you shut your shop down for a long period of time, there's tendencies of you having not seeing people to come to your shop, and when they now find out, I was ill, stigma comes in. What kind of sickness is that one? He comes back looking slimmer than what he used to be, and everybody's like, what is happening to you? What happened to you? So those are one of the issues we have. You know, stigma now comes in sometimes at that point in time. Stigma even comes in the household itself, you know, not even caring whether they might even be subclinical sufferers of the disease.
Coming to term that they have this cough and it can kill. Sometimes they look at you as if you are spinning, you are bringing out two heads when you tell them that this is how the cough works and it can kill them. Especially if they have not had some other symptoms. Probably it's just the ordinary cough. They have not lost weight. They are not coughing out blood. They don't have fever. They are not really sick. They are still going about doing their work. So we have the challenge of them coming to terms that, look, you have this infection in you and you are going to be treated for 6 months. That's for the DSTB. When they look at you, 6 months for what? Just for this ordinary cough that I'm coughing, I'm just saying, it's not doing me anything. Oh, and when it becomes DR, you know, we have extended period of treatment of DR, which is 9 months. They look at you and say, 9 months. Why would they be taking drugs for a whole 9 months? Because they are just coughing. So it is in coming to terms and understanding the type of cough that they have, and then we coming to terms with the length of treatment that they needed to take the drugs to be healed. So many of them will have this challenge, so which involves a lot of counseling, a lot of sitting down with the patients and making the patients to understand what we are talking about, letting the patients know the symptoms and how the cough can progress if we do not treat the patient on time. That one apart, we also have the challenges of people who did not come out on time to be treated, and sometimes they are not able to walk any longer. So we can say that TB affects the income and livelihood of some people, because when they don't come for treatment on time, they get down. They would have been carried around by their relatives one way or the other. Some of them have become impoverished because so many people have spent money. I remember one patient, the TB patient that we treated in those days. He's a young guy who his mother had taken to different herbalist homes. When he opened his back for us to see, we saw different types of incisions that they have gone to the different herbalist homes. They have done a source. They have said it is an evil spirit. They did different type of incisions on him. In fact, the mother is a widow. The piece of land that the father left for them they sold it in Lagos so that the boy could receive treatment. But the money was spent just like that. He still had the cough until somebody told them, look, I have been to Boots, that's Baptist Teaching Hospital Ogbomoso, and I know they used to treat cough there. Why don't you go there? It was they brought the boy from Lagos to Ogbomoso in Boots, and then he was diagnosed with reflux resistant. I remember in those days when we were doing 18 months treatment. So when he was diagnosed, we were able to treat him. He was admitted for 8 months in those days. He was treated, he became well, and then he started receiving his treatment. It was then he was sharing with us his experience of having to go here and there looking for money, getting treatment. So sometimes when patients don't come on time, it makes them to be impoverished. It makes them to lose their means of livelihood. And when they begin treatment, there is no money. And for those who do not even have family members to support them, it becomes a problem for them because DRTB drugs are powerful antibiotics and they need food for sustenance. They cannot take drug on empty stomach. It becomes one of the challenges we have when we put patients on treatment. Because when they don't have food to eat, they will tell you point blank, madam, I cannot take these drugs on empty stomach. So we start to look for how we can support them or get family people who will be able to support them. So these are one of the challenges that DRTB patients have when they start their treatment. Sometimes they also have reactions to the drugs. They have different types of reactions to the drugs. Sometimes they do not want, especially when they start treatment, that of vomiting. For those who start treatment at the community level, for those who start at the treatment center, they have the help of the nurses all the time. Even when they are throwing up or they are vomiting or they have any challenges, the nurses are there to counsel them. They are within the hospital setting. They can easily access the nurses' services. But for those who start treatment at the community level, they would have counseled them on some of the challenges that they may face. But when you are not near the health worker, if I've taken a drug now and I vomit, if there is not somebody with me that is very persistent, that will encourage me to take another one or to keep taking it, I might be tempted not to take the drugs again. So we have the problem of reactions, adverse reactions to the drugs, and sometimes patients may not even want to take the drugs again. But with constant counseling, as health workers, we counsel, we talk to them, we encourage them that they will soon overcome these things. It's just for a little while. Many of them stay on treatment. And then we also have the OPD clinics where they come, they can see the doctors, and they can make their complaints, and it's also helped them to also stay on treatment.
In some homes, when they mentioned, like we had a patient in Ekiti, when she was diagnosed of DRTB, and we did a contact tracing in that house, and the elder sister that she was living with did not have, the husband did not have, they had to trace her out. So that fear will make them not to tell, please don't tell anybody, because they will discriminate them, they will stigmatize them. Just sometimes, like that patient I'm talking about now, if not we were there on time, she was thinking of suicide because of that singular act. So fear of stigmatization and discrimination will tell you, please don't tell them I have a DRTB.
From the time where I take the medicine, my nurse, the woman who they give me the drugs, where they ask me, say, our colleague, that you, because not be only me with that thing do, and I go see plenty people there where they collect the medicine, and some people where they start to collect the medicine, the body they okay. I just see them say, okay, make I just start to collect so that my body will be okay. So as the auntie just start to give me the medicine, come tell me, say, your colleague don't die, you. They give them the medicine, no agree, take, in and put for house. As he won't go give the medicine, they say he don't die. As they just enter the house, they pack all the medicine we give, I'm sure, and they say they no agree take. So made me start to take my medicine, meditate. I will say, God, no, that one will not happen to me.
Bíbá ni sọ̀rọ̀ látọ̀dọ̀ àwọn elétò ìlera torí oríṣiríṣi àkàwé ìrírí wọn gẹ́gẹ́ bí oníṣègùn ni wọ́n fi bá wa sọ̀rọ̀. Wọ́n sọ fún wa níbẹ̀ pé ẹlòmíín lò ṣùgbọ́n kò tẹ̀lé ìlànà tí ó yẹ kó fi lò. so àti nǹkan tí ó padà dé sí lẹ́yìn náà wọ́n tún fún wa ní oríṣiríṣi ìmọ̀ràn pé ẹni tí ó bá lò ní àsìkò bí ẹ kó ṣe lò èsì tó máa rí, ẹni tí ò lò ní àsìkò bí ẹ kó ṣe lò èsì nǹkan tó máa rí. Wọ́n dẹ̀ ní kò sí kódà ìlú òdà kò sẹ́ni tó fẹ́ kú. So lè jẹ́ ìkan tí ó mú mi rò pé dandan kí nìyí o mo lọ́wọ́ ṣe kí n lọ́wọ́ lò ní àsìkò àti bí yẹ kí n lò bí yẹ kí n ṣe lò. Bẹ́ẹ̀ ni mo tẹ̀lé ìlànà tí mo lè ṣe ń lò lọ.
Nípa ṣẹlẹ̀ ni pé ẹ̀mọ̀ yìí pé ẹni tí wọ́n lé ṣé ọ̀sáré ẹni tí wọ́n lé tí ò ṣubú alẹ́ ara wọ̀ yá wọ́n ń fa ní oúnjẹ ẹlọ́fẹ̀ẹ́ wọn ò ná wa lówó wọn ò dá àwọn ẹbí wa láàmú. Tí a bá táwọn òbí àwọn ìyàwó wa tàbáwọn bàbá wa bá fẹ́ ná owó tí ìjọba ná wa lórí ẹ̀ mọ́ yẹ ẹni wọ́n wá yẹ kéèyàn wá mú owó nǹkan wá gbé dàgbó ọ̀yẹ́ kéèyàn gbé dàgbó ẹni tó bá pọ́n bí inú léèrè tí wọ́n bí dáa ẹ kó gbé owó dàgbó ọ̀yẹ́ kó farabalẹ̀ kó gbàtọ́jú ni àwọn tó ṣe bẹ́ẹ̀ jó ní ìtumọ̀ ọ̀gbà tí wọ́n ní kó wọ́n ti dẹ nílẹ̀.
mo fẹ́ fún àwọn tí wọ́n ṣẹ̀ṣẹ̀ fẹ́ bẹ́ẹ̀ láti mọ gbọ̀ngàn tí wọ́n dìkẹ́tì pé wọ́n ní ikọ̀ fẹ́ yìí ìmọ̀ràn tí mo fẹ́ gbà wọ́n ni pé kò ṣeé gbé sára pé bí ìgbà kúkú lóògùn èmi mọ lára mi kán má ṣe bẹ́ẹ̀ torí ó lè mú wọn lẹ́ni tó lè ṣe wọ́n ní jàǹbá nínú ara ó tún lè mú nǹkan tó bá ṣe wọ́n jà kó tún kó bá ẹlòmíì nínú ìdílé wọn gangan torí àrùn yìí jẹ́ àrùn tó yẹ tó bá mọ́kọ tí ò bá gba ìtọ́jú ó lè mú yàwó tó bá mú yàwó tí ò bá gba ìtọ́jú ó lè ran àwọn ọmọ ṣùgbọ́n tí wọ́n bá gba ìmọ̀ràn yẹn ni wọ́n fẹ́ fún ẹni tó ní kó gba ìtọ́jú kó lè lálàáfíà kí ìdílé rẹ̀ gún lè láyọ̀. So ìmọ̀ràn tí mo fẹ́ fún wọn nìyẹn ká mọ̀ sá wípé ìkíní kan lóòótọ́ àrùn yìí a máa máwọn èèyàn níjọ́ tó yẹ pé máa ń pa wọ́n ṣùgbọ́n nísinsìnyí kò pa wọ́n mọ́.
Tóbi ìdí ìbìrì ojú ẹ̀ mọ́lẹ̀ pé mi ò ní wípé ó yẹ kó rí ẹnìkan tí wọ́n máa ń pè ní adviser bóyá ìyàwó ẹ̀ ni o tàbí bàbá rẹ̀ ni o tàbí ìyá ẹ̀ ni o kó gbọ́rọ̀ sí lẹ́nu torí pé tí wọ́n rárí fún tí ó bá gbọ́ ó dòkú nù ẹni tí wọ́n bá rí fún tí ó bá gbọ́ ó dòkú nù torí pé nígbà tí wọ́n bá ti sọ fún yín pé kíní yìí kó ti wà ní ara rẹ o nítòkù ni wípé kọ́ wọn bí ó sì gbàtọ́jú tó sì máa dédédé ẹni tí wọ́n wá ti á fún oògùn tí wọ́n ní kọ́ máa lo oògùn tí tó bá kọ̀ pé kíní kan ẹ ti mọ lọ kánsẹ́lì ní nẹ́ẹ̀dẹ́dẹ́ wọ́n lọ fi sá lọ èmi ló gbé wọ nbẹ́nbẹ́ ní ìsìn ó ṣàdúrà fún mi ni mo ní ntọ́sẹ̀lẹ̀ ni pé make sure pé lo oògùn rẹ déédéé má sì lo yàwá lo oògùn wípé bóyá bí tó ti gbé oògùn ìjọba lọ́wọ́ ẹnìkan tó wá tó lọ mú àgbo mu tàbágbó kan wọ́n tó wá ń fún ọ lù má dàmọ́ràn rẹ o má lo oògùn kankan papọ̀ mọ́ oògùn tí wọ́n bá ti ń fún ọ lọ́sípítù make sure pé lo oògùn yẹn gbogbo bí bá ti lù kó rí ó rí pé ayọ̀ ní tẹ.
I hear some people where they tell me indicate the kind of the thing. Even though I see person with a cough 1 month, 2 weeks, 1 year, 1 month, and even 3 days, I go tell them you go out to hospital and check whether na TB do you. So I tell people how the medicine good to me. So even though my brother the thing just do am, I carry am go the hospital. I collect the drugs for am. She did okay now. She started work.
And if we are going to end TB by 2030, we need to shout more as a nation. We need to shout. I mean, we need to come out. We need to talk aloud. We need to let people know what TB is. We need to take it as we started with HIV. I remember when HIV came, everywhere was flooded with HIV information. You may not pass 2 kilometers without you seeing one HIV information or the other, how it can be prevented, how we can go about not contacting it. You hardly walk. I'm not sure in the whole of Oyo State we have a billboard that talks about TB. I'm not very sure. That are placed in strategic places. These are things we need to do as a nation to let people understand what TB is and to also come out voluntarily for tests. That we don't need to go from house to house driving people when there is enough information. When enough information came out as far as HIV was concerned, you will see a lot of people, even now presently, they are not making any information again. There's no shouting about HIV. But you see people walk to the clinic by themselves, test for HIV, and if they are positive, they are placed on treatment. You can go to so many hospitals and look at the list of patients who are on treatment for HIV. We need to make more noise as far as TB is concerned. People need to have good information. When people have information, they will not stay at home. They will come out for treatment. And when they come out for treatment, they will not get down. They don't have to lose their job. They will not have to lose their source of income before they come for treatment. They will be able to come for treatment on time. Not only that, we will also be able to stop the spread of infection. It is only when people have got the infection and they don't know. Like we always say that a person who has TB can give to 12 to 15 persons in a year. So we will be able to stop. If I'm coughing now and I have the right information, I'll be able to go to the clinic, make my complaints, and I'll be tested and I'll be treated. Since we know that testing is free, treatment is free, the only thing people need is information. And then for those who already come down with drug-resistant TB, we also need support. Many of them are impoverished, I will not lie to you. We have many of them that has lost their job who are not doing anything. I know of a guy we eventually lost. He doesn't have a mother. The father does not stay in Ibadan. He doesn't stay with him. He travels all around. We eventually lost the guy because there was nobody to actually take care of him, to feed him, to give him food and many other things. Even when he had complications, the father was not around. It's not that he's not old enough to do a job. He was old enough to have a job of his own. But because the TB had rendered him so he was very weak. Unfortunately, when they came to tell us that we lost the guy, it pained our hearts so much. Then we also have many of them who move from one town to the other. Lagos is a very big town where everybody goes to earn a source of livelihood. When they come down, they take them back to their places where they are coming from. You find a lot of them coming back to your state, some going to Ondo, some going to Ekiti state. When they get there, they don't have anything. They are not working. And the little, very little that their relatives can support them with. So when we have support for patients who are down, who we know are very down, and then we know that it will help them to stay on treatment, and we can even use them as advocates who will help us to shout about these things and be able to bring others to treatment. So we want to say we need to talk more, we need to give out information, we need to shout, let people know TB is preventable, TB is treatable, and the treatment is free.
So I got to you never give up TB and I just want to do. So I got it for you moving and I'm going to be talking issue.
Let's put an end to TB.
Ó jẹ́ ti tó àsìkò láti fi òpin sí ikọ́ fèé.
Let's end TB.
Let's end TB.